Assalamu alaikum. Welcome everyone on board. Uh, may I know who is the exam candidate among you? Usman, are you appearing in the exam? Okay, Fatima, so you are ready? Okay, so actually today what we will try to discuss is like you can say rheumatological problems in which are important for an anesthetist, and some of the problems like when we talk about rheumatology, usually there are a number of topics you can be asked. One of them is just it's writing. Just give me a second, please. Just a second. Give me. Actually, my stylus is not working. So Zishan, at this time, let me fix my stylus. Can you just think what are the rheumatological problems which are being asked for for anesthetist exam, like what which rheumatological problems you should be thinking?
Sir, there is rheumatoid arthritis, sir,
What else?
ankylosing spondylitis, sir,
Okay, which is more common?
uh, rheumatoid arthritis.
Rheumatoid arthritis
Osteoarthritis.
is osteoarthritis. The most common one is
Osteoarthritis.
not rheumatoid. The most common one is osteoarthritis. Every other patient you will find will have this problem. Okay.
Osteo-
So, okay. So what are the challenges and what will be the problems in these patients?
Sir, basically, in these patient with rheumatoid, sir, you are asking about rheumatoid arthritis or osteoarthritis
Just
or in
generally,
general?
just generally think about it, and then we will.
Sir, generally, sir,
So there will
generally,
be,
Okay,
may I
Zishan,
or
Fatima, speak out.
sir, there will be a problem about the drug taking or medicine taking the patient about rheumatoid arthritis as well as the
Medications.
and yes, sir, and as well as the anatomical or physiological changes that occur in the patient due to
So
that disease.
the practically what you can say, a number of time the patient will have limited physical activity.
Okay, sir, limited physical.
Especially with reference to osteoarthritis. Okay, and if you think about rheumatoid arthritis, so in rheumatoid arthritis there are all the problems. If you read in anesthesia, they can be there. Maybe it is airway problem, whether it is steroids, immunosuppressant, a multisystemic effect, cardiac effects, pulmonary effects. Okay, so all the problems usually which we can expect in any patient in anesthesia floor, it will be there. Okay, so and ankylosing spondylitis also has autoimmune. This is autoimmune problem, and the patient can be on immunosuppressants. Okay, the patient can have problem in when we think about airway that usually the joints. Zishan, can you tell which joints are important or which joints are involved in these problems? So you have to focus on which joints.
and usually the in such patient, uh, s- uh, uh, synovial joints are important, but in for our anesthetist. Cervical joint between C1 and C2, it is most affected, sir. Atlantoaxial joint, sir. Atlantoaxial.
Atlantoaxial, and
And
the
then
other one is
temporomandibular, sir.
okay,
And then we have this cricoarachnoid in our, that joint can also be involved in it.
like
And
laryngeal.
then laryngeal, yes, sir.
Okay, for airway. And generally,
Yes.
what other joints are important for us? Because knee joint
Knee.
will
Yes,
have
sir.
limited physical activity. So this patient will be difficult to assess with reference to cardiovascular reserve. Okay. So knee is
Yes.
important for us. What else?
Mm, sir, hands, elbows, hands, wrist, and wrists, sir, wrists, sir.
Okay, so
Due
if
to position.
like the patient, I am just this is just a practice. So
Yes,
if you have problems in these joints, like in rheumatoid, so actually there is problem with IV lines.
yes, sir.
There is problem in positioning. Okay, especially rheumatoid arthritis, or for example, like you are doing a patient which has rheumatoid arthritis and you want to make the position a sniffing position, like we face in almost all ENT procedures. Okay, so maybe you will end up in having damaging the spinal cord. Okay, so positioning is
Yes, sir.
important. You gave spinal to a patient who had rheumatoid arthritis, and the patient was booked for this TURP, and you give spinal, and you did not assess the limitation of the joint. You try to make it, and you end up in having hip fracture. And these are all possible. These are all possibilities. Okay, patient has osteoarthritis. Patient was taking a lot of medications. Patient has osteoporosis. Yes, actually one thing I forgot is osteoporosis. So osteoporosis is also something very important. So like osteoporotic patient, the patient on steroids can also have osteoporosis. So this patient is coming for anesthesia care, and you end up in having a fracture. So these are the things which are important. So in these patients, I'm just trying to give you an idea. A lot of problems will be common. Another very important problem in this patient with reference to physical activity will be that these patients will be at risk of embolism. Okay. So this is another important thing. And a number of time when the patient is taking steroids, so steroid related obesity, not only because of limited physical activity, so obesity, and then you can think about OSA. So like I'm not saying that every patient will have the same thing, but generally whenever you are having a patient with any osteoarthritis or rheumatoid arthritis or ankylosing spondylitis, you have to, like, these are to do things, and these are common things, so you can easily think about them very easily. Steroids, NSAIDs, multisystemic effects, problem with airway, problem with positioning, limited physical activity, risk of DVT. Okay. So these are sequence of things which you can just enumerate. Anything I miss, Fatima, or anyone, please, anyone can add to it. Yes, Ishan.
Rheumatoid arthritis and osteoarthritis, sir. Common.
Yes. So okay, what is rheumatoid arthritis? Now we
Otherwise,
will
sir, the
just
patient which drugs are taking, they can have this hematological effect
very
on
good.
the
So where we will just go into the
blood bone
details
marrow
of
suppressions
medications.
and
I did not
leukopenia,
touch.
thrombocytopenia. They can also have
Yes,
that.
I did not touch in details of medications. Just but generally, you can, if you have opened up, so we can say bone marrow, liver, kidneys. What else? Heart, neurological. So like all the systems may be involved, but mainly this bone marrow, liver dysfunction, kidneys, renal toxic, and some cardiac depressant effect. Okay. So these are the things which can occur generally. Okay. So what is rheumatoid arthritis? Yes, Fatima, you want to tell?
Sir, actually, I don't go from this topic, but I think
Yes,
it's I try
it's a
to. Yes, sir.
yes, yes.
Autoimmune disease, chronic it's autoimmune disease in which there is symmetrical involvement of the joints,
Hmm.
mostly the small joints.
Okay, listen, Fatima, I just want to make your life easy. If you forget,
Yes.
don't try to recall the definition written in your holy book of Morgan. Okay? If you will try to
Yes, sir.
recall this, you will never be able to recall. Just think, and I can guarantee this is a problem not only of joints, so it is a multisystemic disease with both articular and extra articular manifestation. Can you say this word?
Yes, sir.
It's a
Autoimmune disease,
autoimmune disease with immunological involvement, mean with both articular and
articular
non-articular.
and
Okay, what
non-articular
else? So now
involvement.
you can think, now you can expand your answer. Okay, let's see what is written here. So it's autoimmune, chronic, systemic inflammatory disorders characterized by deforming symmetrical polyarthritis of varying extent and severity, associated with the synovitis of joints and tendons sheath, loss of articular cartilage, and erosion of justra articular bone. If I will be born again, I can never reproduce this. I don't try to memorize such thing which I cannot recall. I don't know. This is not a very reproducible thing. But the thing which you can tell without any problem, it is autoimmune. It is systemic inflammatory disorder. So you can add, as I told you, that it has both articular and extra articular manifestation. Okay, so Fatma, just recall what are extra articular. So let's see the extra articular first, because articular are there. So extra articular, think about it. So I forgot to mention about lungs. So in lungs, because actually the another purpose of doing this topic after respiratory diseases is that we did not touch anything with reference to restrictive lung disease. Okay, so we discuss in detail about obstructive lung disease. So actually in this case you have restrictive lung disease. Okay, so in restrictive lung disease, you have a small lung. Okay, you have very limited FVC. So FE1 is also decreased, but FVC is decreased more than FE1. So this ratio is actually increased or normal. So that is the opposite of what occurs in obstructive lung disease. In obstructive lung disease, the lungs are hyperinflated. Here, lungs are even like you can have like airway pressures are too much. Okay, because the lungs does not have ability to expand properly. Okay, so, like we see, restricted effects, fibrosing alveolitis, costochondral disease, limiting chest wall movement. So, this is another important feature, and this is there also in ankylosing like feature of this HLA-B27. Okay, and I just want to, I know that maybe this is, but I am a patient of this. I have HLA-B27. I don't have ankylosing spondylitis, but I am on an immunosuppressant, and I have this problem. I have recurrent uveitis. I have a lot of back issues and everything. So, this is, you can say, my friendly disease, my friendly topic, because I have a lot of association with a number of diseases which are there in HLA-B27. So, anyways, so you can just, if you forget, I know that sometimes it is difficult to reproduce the charts, but you can just think in heart there is a muscle, there is a pericardium, and there is conducting system. So if you forget, you think everything will be there. You see, myocarditis, endocarditis, valve disease, left ventricular failure. So you don't need to memorize. Okay, if you forget the structure, recall the structure and say one disease from, so it becomes easy. And actually, you name all the diseases in the cardiovascular system, it's there. Pericardial effusion, pericarditis, cardiac tamponade. So this is related to pericardium. Myocarditis, endocarditis, valve disease, and then whenever there is valve disease, there will be left ventricular failure. Atherosclerosis, coronary artery disease, peripheral vasculitis. What else is left? Here, like rheumatoid nodules and pleural effusion. So hematological, because disease itself, and actually only because of the medication patient is taking. Okay, so hematological effects, and then this increased serum fibrinogen and alpha 1 glycoprotein. I don't remember how it happens. Decrease serum albumin, Felty syndrome. So in which there is rheumatoid arthritis, splenomegaly, and neutropenia. So they can ask you, just to tease you, they can ask you such syndromes. Okay, so here neurological peripheral neuropathy autonomic dysfunction. So this is how you can just so like now coming back, how can they ask you this? They can ask you this question in a way that you have a patient of rheumatoid arthritis and they will add a surgery. So rheumatoid arthritis patient coming for laparoscopic cholecystectomy, coming for hernia repair, whatever it is. So your answer, a smart answer can be that I will evaluate the severe, and actually this answer is for all diseases. If that is the way, this is a cheat to answer any scenario based question. I have discussed in detail about scenario based. Unfortunately, you people don't listen to it, but I humbly request you, I will not get millions of dollars through if you guys listen to the discussions which I have posted before in the YouTube channel. It's not a monetized channel, but I will highly request you. So I will tell you the how you should say it for any. I will evaluate the severity of the disease on the basis of history, examination, and relevant investigations. Okay, and I will just evaluate the systemic effects, and I will evaluate the relevance with the anesthesia. So you if you just speak out in that way, actually you will speak out the most important things in 10-20 seconds. Okay, and then whatever they want to explore, they can explore you. Problem what happens in the table viva is that I will say I will take history, I will do examination. So you are going bizarre. You don't have the time to do poetry. You have to speak out orders. You have to speak out very meticulous to the point words. Okay, so if you are speaking about even for rheumatoid arthritis, your answer should be as I spoke as I just spoke. I will evaluate the severity of rheumatoid arthritis on the basis of history, examination, and investigations, because this patient can have involvement of airway. This patient is on steroids, so there will be steroid related problems. The patient is on immunosuppressants, disease modifying anti rheumatoid drugs, and immunosuppressants and steroids and NSAIDs. So, all this can lead to you can just chalk out few important things that this patient can have problem in intubation because of TM necrosis, and also at atlantoaxial subluxation and laryngeal joint involvement. So this is one point. And the other point, you can say that this patient can have anemia, this patient can have restrictive lung disease pattern. So like you can just speak out this thing, and then the next step they can ask you, okay, what history. If they want, in table viva they will never ask you what history you will take. I can guarantee you. In even if you want to tell, if they ask, you can answer, but your initial answer should not be I will take history, I will do examination. This is not in table viva, my dear. In table viva you cannot answer like this. You have to spoke out the you have to speak like a consultant. Okay, that you are discussing a case, a surgical resident or surgical consultant is discussing you, and how you are telling, that is actually the way. So unfortunately you are missing the trick, and then the examiner is irritated and he's asking you some questions and you are not able to answer, and then the vicious cycle starts. And then just to tease you, he can ask you what is Felty syndrome. Felty syndrome will never fail you, I can bet on it. Nobody will fail you on Felty syndrome if even if you are not able to answer. But this will be an irritating question just to check your nerves. Okay, in every topic you will find such a thing. Like you in when they are asking you GB syndrome, they will say what is Miller Fisher syndrome. If they are asking myasthenia gravis, they ask to me what is ice pack test. Okay, if they are asking you COPD, they will ask some examiner used to ask what is match test. Okay, so these are not failure tests. These are sorry, these are not failure points. So don't be distracted in that thing. Try to focus on this thing. Okay, now I will try to keep some of you on board. So Fatma or Zishan, whosoever want to speak out, Hamad, even you can try to speak out. Don't I will, even if you want to speak in Urdu, you speak in, and I will translate. If you have hesitant, please don't be hesitant, try to speak out. Anyways, it's up to you. So like how will you evaluate? Then you can say I can do ECG for a cardiovascular system. You can say I will do an ECG, or if there is a clinical significant history, I can go for further cardiac evaluation, whether it is echo, whether it is this one thallium scan, or like stress echo or whatever. So sequence will be from ECG. With reference to respiratory system, very easy, chest X-ray, and then pulmonary function test. And if there is any hypoxia or anything, you can say then IBGs. Similarly, if you are talking about hematological or liver or renal, you can just say renal functions or liver functions or ultrasound of liver or ultrasound of kidney. That's very simple. You can expand your answer. For reference to this atlantoaxial, you can say MRI or CT scan, or you can say the lateral this what is a special view for it. I think it will be uh, I don't I don't remember the view. There is a special view for seeing it. Okay, so odontoid view or something like that. Maybe I forgot. Anyways, we will just see. So this is how you will tell. And then if they want to ask you some details, they can ask you some details about it. It's like in this. Just a second. Mm, Here there are medication. I think because there are two articles. Let me see whether it is in the second. Just a second, please. Uh, okay, I think I'm missing something. Anyways, so just a second, please. If anyone can recall the view, because I'm just this is just irritating me. What was the name of that view? Anyways, so in with reference to this one, if you're talking about this atlantoaxial subluxation, they will because I remember one with worsened by neck flexion. Okay, so anterior flexion, posterior extension. Okay, so if there is posterior subluxation, the subluxation will be worsened by extension. And if it is anterior subluxation, it will be worsened by flexion. So this is something you should they can ask you. Okay, and there is one destruction of the this one vertical, so it is, I think, very dangerous because it can lead to subluxation of odontoid pec through the foramen magnum. So this is these 3 points, or this three you should be knowing. Okay, and lateral can degenerative to C1 C2, it can lead to spinal nerve compression and vertebral artery compression. So they can ask you these points, you should be knowing. Okay, okay. So,
Sir, kindly can you repeat it?
sorry, here it is written. So, anterior flexion.
Sir, kindly,
Repeat what? Yes, Hamad, please tell me.
सर ये जो व्यूज आपने बताए हैं कि
ये देखो ना आपको, कैन यू सी द
इंटीरियर
स्क्रीन?
सबडक्शन से इंटीरियर सबडक्शन, जी जी
Can you see the screen? It's written in front of you. Okay. So, anterior subluxation will be worsened by neck flexion. Okay. So, if
ओके
you
सर
find in X-ray or in MRI, you find the anterior subluxation, so you will try to avoid flexion. And if you have posterior subluxation, so you will try to avoid excessive neck extension. And if it is vertical, so it can cause the subluxation of odontic pack through the foramen magnum. And if it is lateral or rotately subluxation, it can cause spinal nerve compression or vertebral artery compression. Okay, so this is how you can tell. For TM joint will be clinical, there will be problem in mouth opening. Okay, so like airway clinical history, there are certain things which can occur in addition to, because there may be hoarseness, there may be problem in opening the mouth. So the answer will be, for even practically whatever you do, practically maybe you are able to, because when you give the muscle relaxant, sometimes the some mouth opening improves and maybe you are able to intubate. But in the exam, you don't, you know, you will never tell anything other than awake fiber optic. So the next question will be how to do awake fiber optic. We will just try to have few words about it. But usually you will say, I will assess the severity of the disease and then my plan will be awake fiber optic. So there should not be any answer for other than awake fiber optic. It's now not a safe answer to say anything else. Okay. If the examiner is forcing you, then you can say that maybe if I have glidoscope, because glidoscope blade you can manipulate with minimum neck movement. This is one thing. Or like there is no, actually there is no other safe plan, because if you try to do it, if there is some involvement and you are trying to do with the normal laryngoscopy and normal neck positioning, there you may end up in having problems. So you will say, I will stratify the risk, how much risk is involved, how much is the like disease severity, and then you can plan your management. Okay. So this is how for TM joint problem, because TM joint problem can also be there in ankylosing spondylitis. So it can also cause TM ankylosis. So I think this is, and the individual side effects of the medication, you can just have a look and say it's, because usually the effect will be ultimately will be either bleeding or renal problems or liver problems. So you can say here almost the same effects you can see. Like you see neutropenia, thrombocytopenia, aplastic anemia, fibrosing alveolitis for sulfasalazine, methotrexate, pulmonary toxicity, hepatic cirrhosis, chloroquine, retinopathy, neuromyopathy, cardiomyopathy. Okay. So azathioprine, it's very difficult to memorize separately. It's your luck. Usually in the exam, you will just need to be telling in the in a group. But practically, if they ask you individual, I'm afraid it's very difficult to recall separately. Okay, but you should have some idea what they are looking like. You know, I am taking this medication, Ada adalimumab. I think this is the one which I am taking, anti-TNF. Okay.
एक्सक्यूज मी सर
Yes.
सर अगर ये पेशेंट ऐसा पेशेंट इमरजेंसी में आता है या ऐसी जगह आता है जहाँ पे फैसिलिटीज अवेलेबल नहीं है फाइबर ऑप्टिक की या
Okay.
ग्लाइडोस्कोप की
Okay.
फिर हम एयरवे मैनेजमेंट कैसे करेंगे
Okay, actually, she's asking that if we have this patient in emergency, where we don't have the facility of awake fiber optic, how will you manage? Actually, thing is that practical conduct of anesthesia is something else, and in the exam is something else. In the exam, actually, if the patient is not able to, the patient you cannot open, you are not able to open the mouth of the patient. How will you intubate? So you will say that you will inform the patient that there is no other option other than awake fiber optic, so you will refer the patient to any center where there is facility of awake fiber optic. Otherwise, you can try it as I told you, if you have glidoscope, you can use glidoscope, because any other option, again I say, practical is something else. Maybe we are able to intubate even with limited mouth opening. Okay, you can try to have supraglottic airway device if possible, because maybe you are able to pass LMA, maybe you are able to ventilate the patient. Okay, but again I tell you that there is no safe answer other than awake fiber optic. Okay, so if the patient refuse or there is no facility, or so it there, if you will just have a multidisciplinary team meeting, you will involve the hospital administration, and then you with the surgeon you will decide what to do, because safe option is only awake fiber optic. There is no other option which you can
ओके
say
सर
it's okay,
Excuse
because
me,
if you
sir.
give, yes, yes, Fatima.
Sir, suppose करें कि this patient comes with a trauma and have rheumatoid arthritis. So my answer will be either Mills or tracheostomy.
Very good.
Suppose it's trauma and
Tracheostomy,
it's emergency.
yes, if you and yeah, this is also very good point you added. So if you there is no other option, you can go for tracheostomy, because if there is a
Not
surgery
Mills.
which, okay, so this is, yes, very good. Thanks for adding it, because this is also only a possibility. It will be any only possibility in that scenario. Maybe you can say that if possible, maybe we'll try to do the case in the this one regional, if possible. If any surgery which can be done in regional anesthesia, you can opt for regional anesthesia. Otherwise, these are the things which you can say, and very good you added to point that if there is no other option and you have to go for an emergency surgery, maybe the only option left for you is tracheostomy. Okay.
Okay, thank you, sir.
So actually, in the exam,
The
they will
last
not
time,
ask. Yes.
I think Sir Bilal told not to say tracheostomy, but to say cricothyroidotomy, sir. I think so.
Very good, very good. Actually, the thing is that according to the scenario, according in our exam setup, even if you say tracheostomy, I don't think so. Nobody will fail you. Okay, it depends on the working environment. Bilal is a very special guy. Bilal was in Pakistan. He was in Shaukat Khanum. In Saudi Arabia, he was in King Faisal, and now he is landed up in New York. So don't listen to everything he is saying. I am a miskin person because I have worked in the bloody nonsense setups of Pakistan. I have worked in the periphery of Saudi Arabia. I have worked in a very bad Ministry of Health hospital, and I have the honors to work in King Faisal. So I am a more public person than him. Okay. So of course he's telling the right thing. I'm not saying he's telling the wrong thing. Technically, he's absolutely wrong. It's what he said was front of neck access. Okay.
Yes, sir.
So maybe emergency front of neck access, or if you maybe you are using this percutane, because internationally actually the anesthetist is the one to do this needle, or you can say percutaneous cricothyrotomy. Okay, so there is a I have seen people doing it. So they will just feel the trachea, and they will enter the needle, they will aspirate, then they will pass a guide wire, and then through the guide wire they will dilate. I have seen my consultant doing it when I was junior. So I have seen my consultant doing it. ICU patient actually. So actually, same is the through. This is the domain of anesthetist. So in that case, you need to do ultrasound. Maybe you can do through ultrasound as well. Okay. So through the ultrasound, you will identify the trachea, and then you will puncture, and you will pass the guide wire, and then through it you will do the dilators, and you will put it. So this will be mainly in ICU. In anesthesia forum, of course, if you are privileged to do it, you can do it. But usually the privilege, uh, not for all anesthetists, this privilege will be there. And it is also according to the hospital policy. Okay. So I think we have talked in detail about it. The otherwise, you see, as we said, the basic theory is the same. Again, I'm repeating the same thing, because remember one thing, in the exam, you are not failing on something very big. You are failing on something very simple. Or if you are not, have opened the Pandora's box and you are not able to close it. That's the reason for you to fail. Okay. So if rheumatoid arthritis, osteoarthritis, we will just have a look, few points extra, and ankylosing spondylitis, main things are the same. But the main theory, so the main approach should be, I have a patient with rheumatoid arthritis or ankylosing spondylitis, anything like that. If either it is related to the medications patient is taking or the systemic effects, osteoarthritis is a miskin because it's only damaging a joint. It is not a multisystemic disease. But the medication patient will be taking, we will just try to see which additional medications the patient may be taking other than NSAIDs, steroids, immunosuppressants. There is one thing which is for actually for, I think, osteoporosis, bisphosphonate. And I cannot recall, there are some side effects of bisphosphonate as well. And then the modern anesthesia, the things which are related to osteoarthritis, one will be intra-articular injections of steroids, one will be PRPs, platelet rich plasma. Okay. And then joint replacement. So any patient with osteoarthritis, the further question related to that will be usually the joint replacement. So you should be knowing about total knee replacement or total hip replacement. Hip replacement is less in osteoarthritis, but it is possible. Okay. And with reference to rheumatoid arthritis, we have discussed. So just recall, it's a autoimmune disease, it's an inflammatory disease, multisystemic effects, all systems are involved: liver, kidney, lungs, bone marrow. Okay, so this is how you can easily answer in the exam. The rest of the common the things you can say: ENT consultation, fiber optic nasendoscopy. Another important point in answering any table viva is the involvement of multiple teams. Okay, so multiple teams. So in this case, neurology people, rheumatology people, and hematology people, maybe pulmonologists, maybe cardiologists, you can say that we can have a multidisciplinary team approach with all the subspecialties related to it. Okay. So intraoperative problems in such patient, how will you anesthetize? You can say about you will because now you can just chalk out airway management will be one thing. Okay, then optimization, if any condition can be optimized, maybe you will go for any optimization possible. If the patient has any pleural effusion or any heart failure, you if there elective case, elective surgery, you will try to optimize. This is common answer, not only for this, any optimization. Then another important thing which we have to consider, angiolysis. So is there any problem in angiolysis? You can give you if you have any doubt, the patient can have airway obstruction, you will use angiolysis with care. And this is answer for all conditions. Then think about the preparation. So in preparation, if you have any patient with airway manage difficult airway, so you should be saying that I will be ready for all gadgets related to difficult airway management. So either it is different laryngoscope blades, McCoy blade, okay, then different size bougies, stillet, different size endotracheal tubes, okay. Then if you have glidoscope or video laryngoscope or EU or different things, or at the end, if anything is failing, you should think in your mind one rigid bronchoscope and tracheostomy. So this is very simple answer. You don't need to be worried. For awake fiber optic, okay, how the examiner will be looking at you. I have not done, maybe I can say that clearly, I have not done very few times awake fiber optic. Because in my opinion, if you ask me, it's a bloody nonsense technique. No patient will be happy to do it. It's very difficult. Okay. But of course, in exam, you will always say that as if this is your bread and butter. But practically, I don't like. There are so many things which you can do. Maybe a little bit of sleep, fiber optic, or with a little bit of conscious sedation, not clearly awake. Because in awake fiber optic, you should be thinking about what the things which you have to consider. Number one is anti-sialagogue, use of anti-sialagogue to reduce the secretions. Then you have to block the airway. So whether you are going usually, the better option is nasal, but you can go from oral as well. So better in awake patient, it is better to, because otherwise patient can, you will put the bite block, but still it's more tolerable if you are going nasal route. Okay. So another thing will be decongestant. So they are using pledgets with either epinephrine, sorry, this one, if I have, of course, we don't have this cocaine pledgets, but you can use simple nasal decongestant drops, okay, alongside lidocaine spray, lidocaine jelly, okay. You can say in the exam lidocaine, this one, nebulization, okay. And another important point you should be remembering, that you should be knowing the safe dose. Here in the topicalization, actually the dose of epinephrine, sorry, lidocaine is up to 9 milligram. Okay. And you should be knowing that either it is 4% or 10%. So it is 40 milligram or 100 milligram. So usually in 1 ml, different manufacturers can have different size, but usually 10 puff is equal to 1 ml. 10 puff is equal to 1 ml. So if it is 40 milligram per ml, so each puff will be 4 milligram. And if it is 100 milligram, so each puff will be 10 milligram. So that's how you can calculate the safe toxic dose. This is one thing. So you will say, I will consult the patient. I will tell that this is mandatory. So he has to cooperate with you. And you can have some anxiolysis with Presidex, dexmedetomidine. The advantage is that there is no respiratory depression. Okay. So there is no respiratory depression. Yes, remember one thing, it will, what is difference? Another important point. Can you differentiate, or I'm just highlighting difference. There is difference between respiratory depression and respiratory obstruction. Remember this thing. It will not cause respiratory depression, but it can cause respiratory obstruction. Okay. So try to be very specific. Why? If patient sleep, the tone will be decreased and it still can obstruct. But this is not depression. Depression is the patient is retaining CO2 or patient is becoming hypoxic and patient ventilatory system is not working. That is depression. And all of them are failure. So you should be very clear because you should be using the words meticulously. Respiratory depression is something else. Respiratory obstruction is something else. Respiratory failure is actually the grandfather. All respiratory failure, all these things will lead to respiratory failure. Okay. So respiratory obstruction can be upper airway or lower airway. Respiratory depression is central. So central nervous system or brainstem is not responding to the normal responses to CO2 to oxygen. Okay. So this is, so you should be knowing about this thing. So just by the way it came, so I am explaining to you. So you will calculate for awake fiber optic, you will calculate the safe dose, you will topicalize, and the individual nerve blocks, they can ask you about superior laryngeal block or this recurrent laryngeal block, transtracheal injection. Actually, practically nobody does it. Okay. So practically nobody will do it. So you can say individual blocks, they are more invasive. So practically we just topicalize and rest will be spray as you go. So that is what you can tell. Okay. So I think that's, and this airway management is true for any other problem with difficult airway. Any patient with difficult airway, because thyroid a little different, the rest of the things will be the same evaluation. The little different in thyroid will be that there is tracheomalacia. So as soon as you give, or any, for example, if it is retrosternal or if it is compressing the airway, a little different thing will be that as soon as you give any anesthesia, if the tone is decreased, it can block. So that is a little different, because in that case, this rigid bronchoscope or making the patient in lateral position, or the third thing, maybe you have heard, I have discussed in detail a number of times, this is reverse Salic maneuver, in which you lift the thyroid. Okay, in which you lift the thyroid instead of Salic maneuver in which you press the cricoid. Here you are lifting the thyroid to relieve the pressure. So if there is airway obstruction because of enlarged thyroid or tracheomalacia or any other reason in which airway is blocked, so now you don't have any other option other than you can do a lateral position, you can do this reverse Salic maneuver, or you have to use rigid fiber optics. So lateral, these three things maneuvers you can do. Or another safe thing will be that you never make the patient spontaneous ventilation should not go. Spontaneous ventilation should not go. Okay. So you will try to maintain the spontaneous ventilation, and these things will be the extra things. And another thing is that ramp position, rapid airway management position. Rapid airway management position will be the one to decrease airway pressures. FRC will improve, the abdominal contents will go down, the oral, pharyngeal and laryngeal angles will become straight in a better way. Oral, pharyngeal and laryngeal angle will will be aligned in a better way, and it will help you in intubation. So same words you can use for induction in an obese patient. Same words you can use in a number of scenarios related to thyroid, related to obesity, even related to anywhere you, if you have any doubt. So you can say awake fiber optic. If not possible, then inhalational reduction with preservation of spontaneous ventilation. Check laryngoscopy with some small bolus of propofol, lidocaine, or airway topicalization. If you are able to see, then you can proceed. So this is how you can answer. Someone was asking this thing. So you can answer this question in this way. Okay. So I think we have expanded. I have told so many things extra. So, but
Excuse me, sir.
yes, Fatima.
Sir, my question is this कि अगर ये long case आ जाता है तो tell me 2-3 questions which I have to ask from the patient.
Long case, same things. Same.
It means जैसे मैं उनसे पूछूं कि एक जोड़ों का मसला है और बीमारी कब से है, कौन सी दवाइयां ले रही हैं, other than this कौन से questions होंगे?
Other than listen, I'm trying to make your life easy, and remember one thing in the exam. If you have a long case, any long case, how to rule out liver, how to rule out kidney, how to rule out lungs. You should know the questions for every system. Okay. And don't try to marginalize for any long case separately, because the things are the same. If you have a patient with cardiac or respiratory, the same question will be there: shortness of breath associated with cough, sputum, orthopnea, PND, whether you are able to lie flat, whether you are having a functional class. That's it. So this is, in this question you will rule out cardiovascular system. In liver, abdominal pain, jaundice. Okay. The like any other finding of any other thing which you can have in the liver: swelling, edema, or all other
Ascites.
signs. Yes. Yes, Ishan.
Yes, sir, we can also ask about the ascites, swelling,
Ascites,
abdominal
like
swelling.
Fatima, do you understand? Because these questions are the same, whether the disease is whatsoever disease is. The long case, actually, longest approach is totally different. And I will highly recommend you to listen to my discussions on preoperative anesthesia assessment and planning, in which I have explained in detail how to evaluate a respiratory system, how to evaluate a cardiovascular system, how to evaluate a liver, kidney. So you can just go from simple symptoms, and in the patient you will find some of the symptoms. Okay. And you don't need to be like worried about any what the patient is giving you history for, only that specific history. You have to rule out in any patient, whatsoever patient is there, ask these 5 6 questions, and you can easily say whether the patient has any respiratory problem or cardiovascular problem or liver problem or kidney problem. Okay.
Okay,
Agreed or
sir.
no? Okay. So
Yes, sir.
okay. Any patient you can have this eye problem, but here they have specifically mentioned that because these patients are at risk of this keratoconjunctivitis sicca, risk corneal ulceration. Okay, so this is something they have. Otherwise, the same we discuss about airway management, we discuss about anxiolysis, we discuss about aspiration prophylaxis. I don't think so there is any specific risk other than the medication patient is taking. So this is I think. Then monitoring. So you can say, in addition to standard 1 and standard 2 monitoring, you can go for arterial. Okay. Arterial intra-arterial blood pressure monitoring. Okay. Urine output, and like any other specific condition if you have, then you will tell about it. So urine output, as I told you. Okay. This what is that? CVP, actually, usually cardiac output monitor, if available, they are better, no, relatively non-invasive as compared to CVP. So CVP only for monitoring the volume status, I don't think so anyone does it now, because with the arterial waveform, with the cardiac output monitor, you get it in a better way. If patient is taking steroid, you can tell that I have to give the steroid straight dose steroid replacement. Okay. Then you can say few words about and this fluids. So there is nothing specific. Okay. If there is any electrolyte imbalance, you will treat accordingly. If there is hyperglycemia, you will treat accordingly. Okay. According to like situation. So there is nothing specific. And post-operative, again, you will try to extubate awake. Okay. You can observe the patient in HDU. These are the things which you can say. It's you same thing you will find here. See what they have written. ITU is intensive care unit, or HDU. And for multimodal analgesia, if the patient is on steroids or if the patient is on opioids, for example, so you will say that I will replace them, and then this opioids, if the patient is already on opioids, so you will convert the opioids oral to IV, and that the baseline whatever patient opioids patient is taking, you have to replace. Okay. For example, if the patient is taking 10 milligram of morphine. Okay. So oral, so conversion will be I think half. I'm sorry, I forgot it. I think 1/3 IV. I don't want to tell you wrong. So just basic thing I have told you, you have to convert equipotent conversion from oral to IV, okay, and the baseline will be should be given an extra if needed. Okay, so PCA, through the PCA, either you, because PCA is a totally different topic. In PCA, the things which you should be knowing, that there is a lockout time. So few words about PCA I will, because it came in front, so I will just telling this point about PCA as well. So PCA, because usually in Pakistan in majority of settings not available, it's not very common. Patient control analgesia, the advantage is more patient satisfaction, and there is no window period between the patient feeling the pain and the medication being given. Okay, so patient will have more satisfaction. And then usually there is a lockout time. Okay, I will just write, just a second please. There is a maximum hourly dose. Okay, then there is a bolus, there is a lockout time. Okay, and then there may be a baseline infusion. So how you get, for example, if we say that 10 milligram morphine in 1 hour. Okay, so it means every 6 second patient can have 1 milligram. Okay, so in every 6 minute, I'm sorry, every 6 minute patient can have 1 milligram, not seconds, I'm sorry. Okay, so in 1 hour it will become 10 milligram. So the lockout time is 6 minutes. So before 6 minute, patient, if even if the patient is pressing, he is not getting. Okay, and now how to monitor whether the PCA is sufficient for the patient, about by the presses, how many times the patient is pressing. Okay, for example, if you make it every 6 minutes, and now instead of 10, patient is pressing 20 times, so it means patient is not satisfied. Okay, so there is a record in the PCA, like when the acute pain service team, because another question they can ask you about acute pain service. So acute pain service, you monitor the PCA accordingly. This thing, you are looking at the like the parameters the patient has. And usually whenever we put the patient on PCA, there are certain other medications which we are giving, like paracetamol, like NSAIDs, like for example, any abdominal surgery. So other things are also, like for example, if you are treating a patient post laparotomy, so believe me, ileus is one of the thing which can increase the pain. Okay, and for so you have to think about all the factor which can cause ileus. So that's why the concept of this opioid free anesthesia is now future. Maybe not people, still there are people in the world who don't trust it, but opioid free anesthesia will lead to less chances of ileus. Okay, and a correction of potassium or any other electrolyte imbalance, it can lead to ileus. So if you are talking about multimodal analgesia, if they are discussing with you, you can say in post operative period, maintenance of the factors other than, like patient, if patient is not having a sound sleep, this can create more problem, the patient will be. So these are the things which are adding on. So ileus is with reference to this one abdominal surgery, it's very important. Okay, so this is, I have just told you few points about multimodal analgesia, because in multimodal analgesia there are so many other things. If you have given a regional block, patient is receiving epidural or any wound catheters or local infiltration. So other than opioids or other than these medications, this will be the things which you can have. Actually, I'm I wanted to discuss some more topics today, but I think I have covered some other things other than this thing. I will just try to wrap up in next few minutes. So, rheumatoid arthritis can come in long way case. Rheumatoid arthritis, I myself had one time out of 3 attempts which I had rheumatoid arthritis patient. Okay, so rheumatoid arthritis, I hope you will be able to answer if this case comes to you. And Fatima, the question which you were asking, I hope you understand. If you not, we can have some more discussion specifically on how to where to evaluate patient in long case. I have discussed actually long case a number of times. So just a second. So rheumatoid arthritis, and let me see here some, I think some other things which I just want to discuss. Osteoarthritis. So yes, this is just joint disorder, as I was saying. Gout. Okay. So another thing which is there is gout, in which there is increased uric acid. So other than that, there are some autoimmune disease in this SLE. So Sjogren syndrome, Danlos, Ehlers-Danlos. I don't remember much about this Ehlers-Danlos, but you can have some uh, words about it. Steroids, disease modifying anti-rheumatoid drugs. Uh, this is some. Okay, just a second. Okay. I think this is least likely to be to ask, but you can have a look at here. So targeting infection. Uh, this is for reference to muscle disorders. Baclofen, metho, or this is muscle. This is actually different. This is not with reference to the topic of our discussion today. No, just a second. This is what I was telling you. HLA-B27 in the patient positive. These, I think we have discussed almost all of the common things. Mm, just seeing anything which I have, any important thing which I have missed. I think that's it. So I thought to discuss scoliosis today as well, but I think scoliosis we will try to discuss tomorrow. Okay.
Okay.
Okay. Any question or any comments or anything? So in this topic, you should read about rheumatoid. You should read about rheumatological drugs. You should read about, because we next we will try to cover this scoliosis, and then we will try to cover this hip and knee, and the time, like choice of anesthesia and analgesia for orthopedic procedures. Uh, Usually, this is a quite common topic. It's frequently asked in the exam, because in the ankylosing, sorry, this rheumatoid arthritis is a topic in which an examiner can ask you anything. There are so many things which are which can they can evaluate in this topic. Okay, so I will stop here. So thank you very much. The playlist which I just wanted to show you. Just let me show this. So actually, in this playlist, I had discussed in detail. Just a second. You see, in this, please, I will request you, Fatima, to listen to them. Believe me, if you listen to these play, I know that it does not look very fancy, because I don't have the gadgets to make it more attractive, to make presentation. Unfortunately, I don't have time. If I try to do it, I will not be able to do it. uh, Believe me, after coming from duty, after I sleep and wake up, sometimes I am not able to my GCS is less. So, but still I try to do it. But I have spent a lot of time doing discussions and discussions. So if you listen to them, I can bet on it that your exam will become very easy. So this is the most, if you ask me, the most important playlist in the channel, this one. So listen to renal disease patient for anesthetists, liver disease patient for anesthetists, respiratory disease patient for anesthetists. So listen to them. This will make your life very easy. Okay, and in the Google Drive, I shared this thing a number of times. I will just show you here, because this is what I tell again and again. Okay, just have open this one, how to study, and then here you will find the approach. Okay, this is just a, actually this is a sample. This is not like something out of the world, very simple thing. But if you understand this thing, that any disease, you have to see what is the category, what is the pathology, what is the mechanism of problems, how to diagnose the disease, how to evaluate of the system involved in estimating the severity of disease. So you can use these words for all topics, believe me. And then your shop is reference to airway, cardiac, respiration, because anything which is affecting the cardiorespiratory system, especially cardiac system intraoperatively, it can cause cardiac depression, it can cause failure, arrhythmias, and anything. Anything which is creating problem with the respiratory system, it can have post-operative sequelae. Okay, and intraoperatively, in the sense that maybe you are not able to ventilate properly. Okay, and the rest, if any problem with the liver, all the medications are being metabolized through the liver, or there is other thing, or kidneys, or like, so bone marrow, if there is problem in bone marrow or any problem, that is because of anemia. So oxygen carrying capacity is a problem. If there is problem with the platelets, the patient will not be able to have clotting. So regional anesthesia will be a problem, central new axillary block will be a problem, and surgical hemostasis can be a problem. So that's how you chalk out. And then other things like acid base balance, electrolyte balance, fluid balance. So instead of looking at the pages, try to see in that disease, is there any involvement of these things? So try to present this to start with. In any, rather, this should be the one, this should be the practice you are supposed to do. Whenever any topic, any disease you are reading, read in this way. Okay. And then whatever disease, whatever history, whatever examination, now what you have to do, evaluate the cardiac risk, evaluate the pulmonary risk. Like, for example, today we discuss rheumatoid arthritis. So how will you evaluate the cardiac risk? The involvement of cardiac vascular system with reference to immunosuppressants, with reference to the disease itself, like cardiatis and all the bloody nonsense things were there. So practically, how will they present? With decreased functional capacity, with chest pain, with shortness of breath, with the cough, sputum. So if you have anything like that, then you will go for further testing. And then you will come to know whether the patient has ischemia, whether the patient has failure, how much is the ejection fraction, is there any valvular heart disease, anything. So this will be the cardiac risk. Okay. Pulmonary risk. What is the pulmonary risk? Like, for example, any patient with depressed pulmonary functions. Okay. If the patient does not have good FRC, patient is not able to, like a patient has any obstruction, so that is pulmonary risk. Low albumin is a pulmonary risk factor. Upper abdominal surgery is a pulmonary risk factor. Thoracic surgery is a pulmonary risk factor. Uncontrolled pain is a pulmonary risk factor. If the patient is having atelectasis, stasis, this is a pulmonary risk factor. So that is how, at the end of thinking about that disease, you will chalk out cardiac risk, pulmonary risk, renal risk. For example, how to calculate renal risk? Any patient which is taking NSAIDs, any patient which has anything which is damaging the kidney, like hypertension, like this diabetes. So it's a renal risk. If a patient is diabetic with poorly controlled diabetes, it will cause microvascular nephropathy. Okay.
Nephropathy.
So this is how someone is asking you, think, okay, is there any involvement of the kidneys? Is if it is causing any infections or any pre-renal cause, or if anything related to post-renal. Okay. So this is another thing. Then very simple thing, NSAIDs, use of high dose of NSAIDs. This is a renal risk. Anything, a patient in which you are giving any contrast, this is a renal risk. Any surgery if there is hypoperfusion, hypovolemia, hypotensive anesthesia, okay, any excessive retraction, these are all renal risk. So you will create these renal risk. Then aspiration risk, any patient in which there is either there is gastroparesis or there is problem in bulbar muscles like myasthenia gravis, Parkinson's disease, okay, So you can just think, is there any aspiration risk? Is there any PONV risk? Is there any problem in airway management? So this is the format. If you put all diseases in this format and prepare practice in this way, I can guarantee you will not fail. I can give you a challenge. But this needs a little bit of practice, and this is just like against your common beliefs, because your common belief is to cram the bloody nonsense page of your Morgan Sharif. These things are not written in your I'm sorry to use this word, but this is a reality. You will not find these things in Morgan. You will never find such things in Morgan. Okay, sorry. So I will just finish in few minutes. So then you will see these things. You can just have a look. Any special monitoring needed? Any problem with reference to blood transfusion? Okay. So whenever the word blood transfusion comes, then the blood conservative strategies. You should be thinking about, okay, these are the blood conservative strategies I can do. We will discuss in detail, and I have discussed in this playlist these all things in multiple times. Okay, and then as I was saying, pre-medication, monitoring, induction agent, muscle relaxant, maintenance, analgesia, fluid therapy, recovery, and post-op care. This is in any surgery, any disease. You have to come in the same way. Okay, so yes, with reference to surgery, these are the important point. Is the surgery urgent? Is there any specific surgical risk? Is there any bleeding risk? Is there any critical step in the surgery? Your usual duration? What is the level of anesthesia required? What is the level of analgesia required? Like, for example, if you are doing any orthopedic procedure, the problem can be tourniquet related, and problem can be bleeding, DVT. So these are critical steps or critical things you should be knowing about it. If you are doing any surgery in a specific position, like lithotomy position with head down, prone position. Okay. So any surgery, you filter out these things, and you will find some of the things. So, and that's how you can, like laparoscopic surgery. Three important steps. Remember, insertion of trocar. At that time, you can injure a viscera or injure a vessel, or you can have, if the depth of anesthesia is not good, you can have vasovagal reflex, or oppositely, it can cause a sympathetic response. It can come in the either way. It can cause bradycardia, it can cause tachycardia. Anything can occur. Okay. So this is the time when you insert the trocar. The number two step will be in the creation of pneumoperitoneum. So if you enter a vessel, at that time, when you start the pneumoperitoneum, patient can have carbon dioxide air embolism. Okay. And the same time, again, vagal response can occur, because now the mesentery, the peritoneum is stretched, or there is hemodynamic instability. Okay. The third step is when the CO2 is absorbed. When the CO2 absorbed, the third step will come. So this is how I'm just telling you one example. So I have discussed, believe me, in some of the playlists, I have discussed all the surgeries. So appendix, what are the problems in appendix? What are the problem in lap chole? What are the problems in urological procedure? What are the problems in endoscopy? So actually, you have to plan yourself, and you have to prepare your answers rather than only reading the books. Books will not tell you these things. I can bet on it. These things are not written in the books, and that is the
एक्सक्यूज
reason.
मी सर
Yes, 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 please.
सर मैं यूट्यूब के चैनल पर आपसे जाती हूँ, मुझे मिलता ही नहीं है, प्लेलिस्ट के अंदर सिर्फ
Very good.
2-3 ही बने हुए हैं, तो मुझे बता दें.
How this
Maybe
is a
I'm
big
not good
problem.
in this thing.
Just tell me one thing. If you go to this channel, you will find me and my father sitting over here,
Yes, sir.
and then
Yes, sir.
you will
Then I will go to the playlist.
playlist, and you will find all the playlists: pediatric
No,
anesthesia, ENT.
no. Yes, sir.
This is all. Everything is there.
No, no,
Pediatric.
sir. I will send you the.
Put some water in your mobile, or put your mobile in the water. That's it. Everything is in front of you. Okay. So in this, I have discussed. I have put this surgery based and this problem based discussion. Okay. Elderly, and every time whenever I discuss, I put them in these playlists. So you can have a look. And if you don't understand anything, all of you are welcome to just drop a message. And this in this discussion, uh, yes, this is very good advice. Whosoever put it 2x speed, quick go through, forward it. You don't have to do a research on what I said, okay? Because I'm not doing in informal way. I just discuss the topics and I just try to give you I am trying to simplifying it. I'm not teaching you. I'm just making them simplify because all of you are intelligent. The problem is only that how to produce it and how to extract important things. Even if you are going for MCQs, the problem is not that you are not able to identify the approach, how to differentiate between two goods or how to differentiate between two bads. That is the approach you need. And believe me, if you have a clear concept, you will be able to do it. But unfortunately, if you are doing pick and choose and you are just trying to extract, bypassing it. So Fatima, what's the problem? I don't think so. There is any problem. It's very clear. Okay. So and because I can say by very confident that I'm not having any conflict of interest because my channel is not monetized. Even if you look at it or don't look at it, I have no problem. Okay. So okay, so I will stop here. And tomorrow, inshallah, we will try to discuss scoliosis. And if next, like I will try to discuss hip surgery. Okay. So
Thank you, sir.
thank you very much. And
Thank you, sir.
anything you don't understand, you can just drop a message with the link that we were discussing. We were listening to this thing, and in this link, in this minute, we don't understand. I will be happy to answer you. Okay. Thank you very
Thanks.
much. Bye bye.